Okay, good morning, ladies and gentlemen. Can you hear me?
Yes, you can. Can you try to move your slides?
Okay.
Okay, they
Are
are
they
moving.
moving?
Yes, yeah.
All right. All right. So my name is Dr. Mvundura, a second year registrar at Sakok from Stumza Hospital. I'm currently attached at Salim Gabi, FMU unit. So today I'll be presenting a case of a case of encephalocele. So I'll be presenting Mrs. MC, 18 years old, who is a housewife from Chinhoyi. She was para or gravida 1 at the time of presentation. Her last normal menstrual period was 7 June 2025, and she had an estimated delivery date of 14 March 2026. Her EGA was 39 plus 6 weeks. So she came in as a referral from Mbare Polyclinic with an ultrasound scan obstetrics that was suggestive of fetal defects on the 13th of March. On the history of her pregnancy, it was planned. However, she did not receive any preconceptional counseling. She did not receive a preconceptional folate. She then booked a pregnancy at 12 weeks, and she had a total of 7 ANC visits. At the initial visit, she was screened for HIV, which was negative, and they did an ultrasound scan obstetrics at 12 weeks, which the patient self-reported that it was normal, but she didn't have the scan. 6 of her visits were at Mtala Clinic in Chinhoyi, and the 7th was at Mbare Polyclinic. She had moved to Mbare Polyclinic because she had moved to her mother's place in preparation for delivery. She has no history of chronic illnesses. She was not taking any medication. On the social history, she stays in Chinhoyi with her husband, who is self-employed. So the investigations that were done during the entire pregnancy, she did not have an aneuploid screen. She only reported that her first trimester scan was normal, but we did not see the specifics. And she did not have the fetal anomaly scan. At 20 weeks, she was also not screened for neural tube defects. She did not have random blood sugar done during a booking visit, and she was never screened for torches. Well, she didn't have an FBC result or a blood grouping done. So when she presented at FMU, an ultrasound scan was done, and it showed a single live intrauterine fetus with estimated fetal weight of 3,496, which was appropriate for gestational age. Presentation was cephalic. There was a large encephalocele that was measuring 130 millimeters with internal echoes that were suggestive of herniated neural tissue from the posterior fossa. And this was complicated by severe ventriculomegaly. The biparietal diameter was 101.9 millimeters. The head circumference was 36.9 and was 369 millimeters. The left ventricle measured 39.5 millimeters. The right ventricle measured 34 millimeters. In the posterior fossa, the cerebellum was herniated into the encephalocele. And some heart abnormalities were noted, but the abnormalities were not characterized. She was due to have another scan. However, she went into labor before the scan to complete some of the investigations were done. So yeah, the pictures, this one is showing ventriculomegaly. Ventriculomegaly, the other ventricle is measuring 3.40 centimeters, the other one is measuring 3.95 centimeters. Then this is the picture of the cephalocele, showing the widest diameter. Then inside there's another cyst there, inside an echogenic mass, and the cyst was also measured it was 2.76 in diameter. Okay, so here, so the encephalocele 12.86 centimeters in the widest diameter. Then on this picture, we are seeing a defect in the calvarium, in the skull bones, where where there's herniation of posterior fossa contents. Yeah, on this picture, we are seeing. Hello, on this picture, we are seeing a measurement of the biparietal diameter. And here we are seeing the measurement of the head circumference. So the differentials were Chiari, our main differential was Chiari III malformation. Other conditions that may present with a mass on the scalp, epidermal inclusion cysts, subcutaneous edema, in fetal eye drops, cephalohematoma, but these ones will have different characteristics, distinguishing characteristics from an encephalocele. So when on the day of the ultrasound scan, that's when the patient went into labor, and an emergency cesarean section was ordered. So she then, an emergency cesarean section was ordered. Initially, she was planned for elective cesarean section, which was to be done on the 23rd. However, she went into labor earlier, and she went on to deliver a fetus with a birth weight of 2,820 grams. ABGA was 410, 510, with a head circumference of 410 millimeters. So yeah, the pictures of the baby taken with the consent of the mother. So during delivery, there was trauma to the encephalocele, and it started bleeding and draining fluid. So they had to cover it with that plastic. And the child was in respiratory distress. So going on to the discussion.
Okay, thank you. So at this point in time, I'll give time to the floor. Any questions on the case or any contributions? Would you want to summarize the case? Just in a nutshell, the ultrasound scan findings.
Okay. So in summary, this is a case of a late diagnosis of a severe fetal defect, which was characterized by bilateral ventriculomegaly associated with an encephalocele.
Okay, thank you. So I will start. I just have a few contributions. So yeah, so this is a case where we want to interrogate the risk factors folate deficiency, late booking in our setting so that we can help this patient. Does she have genetic predisposition, maternal diabetes? Yes, in this patient it wasn't tested, but did she have symptoms? And has she been exposed to teratogens, for example, anti-epileptics? Then there's a patient who also have many missed opportunities. Yes, she had a first trimester scan, but this could be a time where we would have told her she need to come back for an anomaly scan between 18 to 22 weeks. I don't know what's the routine role of fetal protein, but yes, in this case, maybe it had been missed in the first trimester scan. A knockout translucent scan wasn't done. I didn't hear the comment on that one. So I think she had so many missed opportunities at multiple levels. Then again, if she had come in earlier, and we had seen the encephalocele, I think there's a role for MRI. where we would be able to really characterize the encephalocele, which is good for an MDT. If she had an MDT, if she had came earlier on with a neurosurgeon, where we would plan for management of this patient, surgical management, and also counseling on prognosis. And I don't know whether I couldn't hear properly whether she had multiple anomalies, where we could try to see whether it was due to chromosomal anomalies and recommend amniocentesis. So if she had come in earlier and she had all those investigations, and then we also discuss on termination or feticide for late. Thank you. I'll leave the floor to other contribution. Okay, there seems to be no questions. You can go into discussion, though.
Yeah. Okay. Going on to the discussion, Chiari III malformation
Sorry, Dr.
is an extremely.
Sarah. Can I
Yes, over.
just
Yes, over to Dr. Verenk. Yes.
Thank you. I'm sorry, I missed this description of the all right. So there was a nation at the posterior fossa. You said the structures that were there were the cerebellum and the ventricles. Were they also going out or they were inside in the encephalocele?
Yeah, so yeah, I'm not really sure about that, but on the description, it wasn't mentioned.
Mm-hmm. But the posterior fossa was clearly visualized.
No, the posterior fossa.
So the cerebellum was herniated in the. Did you guys have a chit chat with the neurosurgeons at any point on seeing this case?
Okay, so the case was so unfortunately we couldn't have a chat with the neuros because on the day that she was scanned, she was already in labor. She was already at 1 centimeter in labor.
Did you invite them to this meeting so that they can give a comment?
Unfortunately, no.
So next time, make sure you invite the relevant specialist of the defect we will be discussing. Thank you.
Okay, so Chiari III malformation is an extremely rare anomaly which is characterized by a small posterior fossa and low occipital or high cervical encephalocele with herniation of the posterior fossa contents that may include the cerebellum, the brainstem, occipital lobe, and the ventricles. It may be associated with hydrocephalus.
Sorry, Dr. Mvundura. I think Dr. Kumbula's hand is up, was up.
Okay, it's okay. Sorry.
Yes. Over to you, Dr. Mvundura.
Thank you. Good morning. I understand there was an estimated fetal weight of about 3.4. What was the birth weight?
So the birth weight was 2,820 grams.
Okay. So I meant to ask, what is the reliability of using head circumference in such a case where there is an encephalocele? Do you consider the herniated tissues as part of the head circumference measurement, or you exclude it, or you modify the estimated fetal weight based on reliable parameters like the AC, BPD, and female length?
Okay, Dr. Mzara.
Maybe I can help him.
May you please help me? Yeah.
Okay, so using the machine, it was difficult to use the other parameters. It was difficult to then use the AC and Fimaling because I think the machine was already programmed. I don't know. I had difficulties to use the other parameters. So we ended up just using including the formula. We ended up using the formula that includes the head circumference. And we may have, we actually overestimated the fetal weight because of that.
Okay, thank you.
Okay, thank you.
Hello, Dr. Mvundura.
Yes, thank you. You can move on. Thank you, Dr. Ndaguru.
Oh, okay, it's okay. Thank you, Dr. Ndaguru. The etiology arises from neural tube closure defects, and the contributing factors are folate deficiency and a genetic susceptibility. In the neonate, we can see a visible encephalocele. They may develop respiratory distress, swallowing difficulties, and cranial nerve dysfunction. Then in infancy, if they survive, they may have a developmental delay, seizures, and hydrocephalus. The prognosis is generally poor with a high mortality. A termination of pregnancy may be advised if it's detected early. In some patients, they may benefit from surgical, they can be salvaged by surgical repair, where there is reduction of herniated contents, closure of the defect, and a VP shunt in those with hydrocephalus. They may need airway and feeding support and management of seizures. So I've looked at some cases that were managed in the South Korean Journal of Neurosurgery, where they managed about 15 cases with surgery. However, the majority of them developed neurodevelopmental delays, but they concluded that surgery is a viable option to salvage some of the cases. However, it's still a case with generally poor and high mortality. So I'll end my presentation here. Thank you. Over to you, Chair.
Okay, thank you, Dr. Mvundura, for such a detailed presentation. I shall leave time to the floor for any contribution or questions. Any contribution? I just wanted to ask, do you know where the patient is right now, and whether she got counseling for folic acid? There's a question
Okay.
online.
Yeah, sure.
How common is this condition in Southern Africa? If you were able to research on that.
Okay. Unfortunately, I couldn't get any. I couldn't get the prevalence in Southern Africa, but I just got the general. So they were saying that generally these are neural tube defects. Defects are common in sub-Saharan Africa, as opposed to countries where folate is prenatal folate is generally offered. So I will have to look for the exact prevalence.
Okay, thank you. Do we have any other questions or contributions? And so what's your takeaway home message for the benefit of others?
Okay, so yeah, the take-home message is that during the if a first trimester scan is done properly, it can major malformations may be detected, and that we should offer pregnant mothers the 20-week fetal anomaly scan. It will help to detect these conditions earlier, where management it can be planned on time, and also that we should counsel women of reproductive age to do preconceptional counseling and to take a folate before they conceive, because taking it after they've conceived, it won't help them much. Like for her, she was offered ranferon at 12 weeks after she had conceived, but it wouldn't have helped her much, because folate is much needed during the early stages of pregnancy. Yeah, so that will be my take.
Okay, thank you. And should also on the folate should also fit on the criteria where you now need a folate at a higher dose instead of the 400 micrograms, because one of the indication is the patient had a previous history of anomaly, which can be attributed to folate. I will leave this time to Ms. Madembo.
Okay, I wanted to ask, since you had said that the patient also had some uncharacterized heart defects, unfortunately, she delivered before she had been assessed on the heart. So do you want to call this probably just a Chiari malformation, or probably people are dealing with some syndrome of some sort? I ask, so probably it also would help in the counseling of the woman for future pregnancies.
Yeah, yes, I would consider the diagnosis of maybe a chromosomal abnormality, and maybe more tests can be done on the fetus to rule out chromosomal abnormalities for future counseling.
Okay, thank you. The last question from the group is Chiari III compatible with life?
So yeah, so there are cases that do survive, but in general, which has got a high mortality. Either they die early in infancy, or if they are to survive, they may have severe neurodevelopmental problems. So I would say there are cases that are compatible with life.
Okay, thank you. Were you able to get those cases from literature? Are the ones we were talking about?
Yes, so from the Korean Journal of Neurosurgery, they described 15 cases they operated on that actually survived. But they described various neurodevelopmental problems, including hypotonia, delayed milestones, feeding problems, and many other neurodevelopmental problems.
All right. Thank you. I don't see any more hands up from the group. Do we have any other contributions?
I just wanted to comment and say what Dr. Madembo mentioned is very important. Whenever you have more than one defect on a baby, we expect you to search for possible syndromes aligned to that condition. If you go to the online Mendelian inheritance in men, it's there on the website called Online Mendelian Inheritance in Men. You can actually try to search and see which syndromes are more likely, so that we deepen our discussion a little bit, so that we don't just scratch the surface of things. So try to do that. Anyone who clocks a baby with more than one defect, always try to find which potential syndromes could be responsible for those lesions. You may ask and say, why do you have to do that? Obviously, we are going to come across couples who would want to know if there's a potential syndrome, and they would want to do tests. But when you are ordering syndrome, if you are checking for syndromes, even the laboratory would want to know which syndromes is the doctor looking for on a specific patient, because the panels required to test different kind of syndromes vary depending on the syndrome that you as a doctor will be suspecting. We are working in a society where we do not have clinical geneticists working with us. So that means we have to become the geneticists now ourselves, because we do not have anyone to support us in doing the genetic triaging of our cases at the moment. So please be aware of this, that more is now required of us to work through the syndromic pictures of the cases we see, so that we really go down into issues, and also we deepen our counseling. We also direct our testing so that our testing is more directed towards what is more likely. I think those were my comments on the case. But yeah, I think those were my comments. Thank you.
Thank you very much, Dr. Verenga, for the interest.
Thank you, Dr. Verenga, for the contribution. Do we have any other contributions from the floor? May I kindly unmute. I don't see any hand up or any more messages. So at this point in time, are there any housekeeping issues?
Dr. Msara, maybe to just announce that I think probably Mr. Kumbula may take the announcement and announce the refresher course which is coming, may take over, announce the refresher course which is coming, so that people are aware that there's a refresher course to be attended and so forth.
Okay, over to you, Mr. Kumbula.
Okay, thank you so much, Dr. Msar. Good morning, everyone, once again. So I'm Lyman Kumbula, the Secretary General for Fetal Medicine Society of Zimbabwe. So we have a refresher course, which we had initially planned for April, but because of logistical issues, we are moving the refresher course to 15 to 16 May 2026. And the event will take place in Bulawayo. It will be a 2-day course, and it is relevant to radiographers, sonographers, midwives, obstetricians, gynecologists, as well as other healthcare professionals who are involved in maternal and fetal care. So the aim of the refresher course is to standardize fetal medicine referral, just like this case we've been discussing, as well as management pathways through a combination of practical training, which we'll do on the first day at UBH, as well as a theory session that will take place at Cresta in Bulawayo. So we had circulated a flyer on WhatsApp groups, and we'll share another one. If you had missed it, we'll share another one later today. So we believe that this workshop will provide valuable opportunity for members as well as health professionals to enhance knowledge as well as practical skills. So take time to dedicate these 2 days for this training that will happen in Bulawayo. So those who have contacts in Bulawayo, also share the flyer with them so that they can also benefit from this training. And don't hesitate to contact either myself or Ms. Thelma for any further information. Thank you.
Thank you so much, Mr. Kumbula. Do we have any questions pertaining that? or any other contribution? Okay, I see no hand raised up, so I think that brings us to the end of the meeting. We meet again next week for an audit. Thank you.